Hi, my name is Dr. Gary LeKander. I am a pulmonary and critical care specialist working at Healdsburg District Hospital. Today, I serve as the medical director, not only of the ICU, but also of respiratory therapy. I also work on various committees at the hospital, and I'm the chairperson of the medicine committee today. And recently, I started to be the chief of staff, representing the medical staff in hospital matters. As a pulmonologist, I see a wide variety of lung problems. And my outpatients are referred to me for asthma, for COPD, which is also known as emphysema, for difficulty breathing, shortness of breath, wheezing, chronic cough. I get patients referred to me for evaluation of abnormal findings on x-rays or CAT scans. But one of the common problems that are referred to pulmonary specialists like myself for evaluation is in the evaluation and treatment of chronic cough. As a matter of fact, chronic cough makes up about 40% of the pulmonary consultation referrals across the country. So it's a very common problem. And I thought today we might spend some time talking about chronic cough. We divide cough into three different types. One is acute, the next is subacute, and then we have chronic cough, the one that we're interested in today. But an acute cough is up to 3 weeks in duration, and most commonly it is due to an acute infection or an infectious process, such as a virus or a bacteria. And that's the one that usually causes that brand new cough out of the blue for up to 3 weeks. If it persists after that from 3 to 8 weeks, it's categorized as a subacute cough, and it's mostly this post-inflammatory, post-infectious etiology that your lungs are still irritated and we still cough up to 8 weeks duration. And if it happens to last longer than 8 weeks, then we kind of switch into a chronic cough category, which can have multiple etiologies. Before we look more closely at chronic cough, let's look at how a cough is produced. There's things called receptors that are located through mostly the upper part of the body, but mostly primarily in the lungs, but can also be outside of lungs that get stimulated that start the cough reflex. And these receptors are, again, mostly in the lungs, but can be in the upper airway. There's some in the sinuses and the back of the throat. There's some around the heart, and the lining of the heart called the pericardium. There's some in the esophagus, the tube that goes down into our stomach. And then the stomach itself has some receptors that can start a cough reflex. So something irritates these receptors. The receptors then send a signal up into the brain. There's a cough center located up in the area called the medulla, and that sends a neurologic signal back down to the respiratory muscles to cause that forceful expiration of air out of lungs. We all know what that is. So you get a signal down and you cough. And that's mostly produced by the muscles of the diaphragm. They're the strongest muscles of the respiratory system, and they contract very quickly to expel the air out of your lungs. So that's the cough reflex. So let's now talk a bit more about chronic cough in detail. When a patient is referred to a pulmonologist for chronic cough, we realize that one of three things is the cause of this in the vast majority of cases. As a matter of fact, between 80 and 90% of the causes of chronic cough can be attributed to three different things. One is the upper airway cough syndrome, which is often thought of as postnasal drainage. Number two is asthma, which is either undiagnosed or untreated completely. And the third is from the GI system, the reflux or the GERD. There is a much smaller group of causes of chronic cough that make up the other 10 to 20% of cases that are referred to pulmonologists. And these can be things such as common as a post-inflammatory infectious cough that can last longer than the 8 weeks duration we talked about earlier. It can also be due to medications that cause a cough, and the most common one is an ACE inhibitor, something like lisinopril or enalapril. Those medicines cause a chronic cough in 5 to 10% of the people that are started on them. And that usually happens between 1 to 3 months of starting that new medication. Other chronic coughs can be due to other structural airway issues, such as chronic bronchitis, which is an ongoing irritation of the lungs, frequently associated with COPD. Structural changes in the lungs, permanent destruction due to bronchiectasis, also very commonly has a daily cough and sputum production. And matter of fact, that's part of the diagnosis. Other mass lesions that press on the cough receptors that can cause a cough happen with things like cancers or malignancies. And then another etiology to think about is aspiration. When you put liquids or solids down into the lungs as one swallows or coming up from the GI system and reflux, that gets into the lungs, and that will cause a direct irritation and a cough. But all of those combined make up 10 to 20% of the chronic coughs, and the vast majority, as I mentioned, are due to the three most common causes, and that is the upper airway cough syndrome, the asthma, and the GERD. In talking about these three leading causes of chronic cough, the first one to think about is the upper airway cough syndrome, and this is commonly caused or called postnasal drainage. And just as it says, it's anything that drains from the back of the nose, postnasal, down the back of the throat. And it gets into the larynx, the upper airway that's above the vocal cords there. And there's receptors there that cause a cough. Possibly, the drainage can go past or hit the vocal cords and then down into the lungs, and also cause a more local location of the chronic cough. Now, this postnasal drip can be due to lots of issues. It could be allergic in origin, that by itself is the most common cause of postnasal drainage, but it also can be non-allergic due to things like sinus structural issues or sinus congestion, sinus infection, sinusitis. So any process that produces secretions in the upper airway as it drains down the back of your throat often causes that throat clearing behavior, but also a cough, and hence the chronic cough. Testing for this or identifying it as etiology sometimes requires looking in the sinus passages, often by our ears, nose, and throat doctors or otolaryngologists who do an indirect laryngoscopy. They put a tiny camera back through the nose and into the back of the throat, and they can see irritation or drainage or mucosal changes suggestive of the postnasal drip as the etiology of a chronic cough. Often, however, we just empirically treat for allergies or non-allergic rhinitis and postnasal drainage. So that often includes a nasal rinse kit, nasal steroid antihistamine trial. And then usually I recommend several months. Sometimes it takes longer than a short few days or a few weeks to get some overall effect. So a treatment for several weeks to a month or two, and it gets better, is supportive evidence that that's the etiology of the chronic cough. And often that's what we do in the pulmonary clinic. In thinking about the number two cause, we have reflux disease or gastroesophageal reflux disease, GERD. Reflux, of course, starts with the stomach. It can cause heartburn. You might have sensation of sour taste in the mouth. Sometimes it occurs during the day, and often it occurs at night when we lay down, and the stomach acid has a chance to shoot out of the stomach into the esophagus. And we know that there's various grades of reflux that can cause a chronic cough. The chronic cough that can be produced when the acid hit comes all the way up to the larynx, especially as you're laying flat. And it doesn't even have to get up through that into the lungs. There's receptors right there in the larynx that can cause the cough. Or as I just mentioned, sometimes it works its way through, goes down past the vocal cords into the lungs, and has a direct irritant effect on the upper trachea and down in the lower airways, and hit those cough receptors, causing your chronic cough. And that's the most kind that's related to heartburn or reflux or GERD disease. However, there is another etiology of the chronic cough that we're aware of, and that's this silent reflux. And here the acid only has to make it barely out of the stomach into the lower part of the esophagus, where there's also cough receptors located. And just that little bit of stomach content making its way into the bottom of the esophagus will cause you to have a cough. So it doesn't even have to work its way all the way up. Now, in making this diagnosis, sometimes we do an empiric treatment of Prilosec and elevating the head of your bed. Again, that's not putting pillows under there, but the head of the bed, putting bricks or wood or using a hospital type bed that goes up. And you want to be at least 6 to 8 inches off the ground to put gravity back into play to keep the acid in the stomach. And if you did that along with a H2 blocker trial, something like Pepcid or Protonix or Prilosec or Omeprazole, you do that for a couple of months again and see if that has any effect on your cough. And if it improves, then that's good evidence that reflux was at a primary cause of a chronic cough. Alternatively, sometimes someone will get an evaluation through the GI department, undergoing endoscopy, where they put a tube through the stomach or through the mouth down into the stomach and look for changes of chronic reflux. And even if that is unrevealing, there's another test that can be done through the GI department called a 24-hour pH probe. And what that entails is a small tube goes through your nose down in the esophagus and sits there for 24 hours, just like it's labeled. And it looks for acid that comes off unrecognized, and it will have a lower pH than the typical esophagus pH. So that is proof that there is silent or retrograde reflux or even known reflux. And that's a very sensitive test. If that's positive, it tells you that that's a good chance that's a cause of your chronic cough. Almost 90% of the time, it gives you good results. So if it's there, it's a good test to find it. So those are the ways of looking at chronic GERD and causing a chronic cough, and then treatment, elevate the head of the bed or a PPI or H2 trial. So now moving on to the third most leading cause of chronic cough, which is asthma. As I mentioned earlier, this kind of asthma causing a cough can be either undiagnosed or unsuspected, or the other kind that is diagnosed but insufficiently treated. Asthma that has a cough associated with it also can have other symptoms such as wheezing, chest tightness, or shortness of breath. When this type of asthma has only a cough, it's known as a cough variant asthma. This type of asthma typically can be made better or worse by environmental factors like cold air or hot air, dry air, even humid air. It depends on the individual person. Also, exposures to things in the environment like dust or fragrances can make a cough variant asthma a bit worse and suggest that diagnosis. There's one medication called a beta blocker that when it causes a chronic cough, think about asthma due to the beta blocker presenting as a chronic cough. To make the diagnosis of a cough-related asthma requires formal testing. The most common kind is pulmonary function testing. This is typically ordered by the physician to be done in a hospital or an outpatient clinic. It can look for the obstruction after a bronchodilator is administered, such as albuterol. Asthma is easily diagnosed with pulmonary function testing. Alternatively, there's a newer test called a nitric oxide exhaled test that looks for a percentage of nitric oxide in your exhaled breath that is associated above a certain cutoff with asthma. And so those are typically the two modalities outside of just clinical presentation that help us make this diagnosis of asthma. And again, this is the third leading cause of chronic cough. So now we've covered the three most common causes of chronic cough, that being upper airway cough syndrome, GERD or reflux, or asthma. In a pulmonary consultation for chronic cough, my goal is to try to figure out which one of these areas is most likely the cause of chronic cough. If I can do that, then we can make some empiric treatment recommendations. This could be elevate the head of the bed and take Pepcid, or treat allergies with nasal rinse kit and steroids. And we'd also order empiric or more diagnostic testing to look into that one etiology. So again, if it's allergies, you can do formal allergy testing. Or if we think it's asthma, order the pulmonary function test. And the hope is that with the empiric treatment, the cough gets better, and with the diagnostic testing, we can confirm the clinical suspicion. The overall goal of treatment of chronic cough is to make it better. And by making it better, often it doesn't mean making it completely go away. It just means making it better. Sometimes, even though we know what's causing it, the goal is just to try to make the cough better. In closing, thank you for letting me talk about chronic cough. It's a problem that I see frequently in my outpatient pulmonary practice. It's a problem that's very prevalent in our local community. A lot of people have a chronic cough. Remember the three most likely causes of chronic cough that we talked about: the upper airway cough syndrome, the GERD or reflux, and the asthma. If you happen to have a chronic cough and you're worried about any of these, the best place to start is working with your primary care provider. They often can start ordering the diagnostic studies of choice and empiric treatment. If you have persistent symptoms, then referral to a pulmonary specialist like myself is the next step. I hope this helps your understanding of chronic cough. Thank you.